Coming to the introduction, malnutrition or undernutrition is a state in which deficiency either in total energy or in protein or other nutrients due to reduction in the body cell mass and organ dysfunction can be a result of any combination of inadequate intake, reduced absorption, or increased requirement. The different phases of critical illness are generally described as acute phase and a post-acute phase. Acute phase has two phases. Early phase, initially in 1 to 2 days, and late phase coming to the 3 to 7 days, previously known as the ebb phase and the flow phase. In ebb phase or early phase, metabolically instable and is having severe increase in catabolism. And in flow phase or late phase, it is significant muscle wasting and stabilization of the metabolic disturbances. Post-acute phase is a chronic phase, follows can be an improvement and rehabilitation or persistent inflammatory or catabolic state and prolonged hospitalization. That is known as PICS, that is chronicity and prolonged inflammatory and catabolic syndrome. Aim of the nutritional support is to prevent and treat both the micronutrient deficiency and the macronutrient deficiency. Medical nutritional therapy shall be considered for all the patients in ICU, mainly for staying mainly for more than 48 hours. The American Society for Parenteral and Enteral Nutrition and European Society for Clinical Nutrition and Metabolism, ASPEN and ESPEN, provides the guideline for the management of critically ill patient nutritional status. Coming to the assessment of nutritional status, it is difficult to assess. Anthropometric measurements are usually for population and not for individuals. Biochemical test varies with acute and chronic phase. BMI does not reflect acute changes but is a predictor of mortality in seriously ill patients. The most useful measure of status is a targeted history and examination. One such method is widely acceptedly known as subjective global assessment, which include history. History includes weight change, both chronic over 6 months and acute over 2 weeks, changes in food intake, gastrointestinal symptoms, nausea, vomiting, diarrhea, and anorexia, and functional impairment. Combined with the physical examination, looking for a loss of subcutaneous fat, looking at chest and triceps, muscle wasting in temporal region, deltoid and gluteal, edema, and ascites. Other tools may include NICE, the UK's National Institute of Healthcare and Excellence Malnutrition Universal Screening Tool, that is MUST, identify both obese, malnourished, or at risk for nutritional risk, uses the BMI, weight loss, and acute disease effect score. And another score is Nutrix score. Then coming to the nutritional requirement. During acute illness, the aim is to meet patient energy expenditure, thus decreasing negative energy balance. Ideally, energy expenditure should be measured during indirect calorimetry, which measures the oxygen consumption, which can be obtained from the pulmonary artery catheter, and VCO2, that is oxygen, carbon dioxide production, which can be measured from the ventilator. If this is not available, feeding equations like Harris-Benedict Schofield equation, that is BMR is equal to 13.75 into weight in kilogram plus 5 into height in centimeter minus 6.78 into age in years plus 66. This equation can be used. Usually, this will give a result of around 25 kilocalorie per kilogram per day. This usually is an febrile healthy individual. But modification can be fever increases the resting energy expenditure by 10% for each 1 degree Celsius increase. Sepsis increases by 9%, surgery increases by 6%, burns increases by 6%. The requirement of protein is around 1.5 gram per kilogram per day, ranges from 1.2 to 2 gram per kilogram per day. 2 in severe catabolic state like burns and trauma, it will provide about 5.3 kilocalorie per gram. Lipid should be 40% of the total calorie, provides 9.3 kilocalorie per gram. Carbohydrate is 3.74 kilocalorie per gram, which provides the remaining quantity of the energy. Protein proportion is usually measured in terms of calorie-nitrogen ratio. In that, 100:1 is the ideal calorie-nitrogen ratio. Coming to the route of administration, can be starting as a trophic feed, that is 10 to 20 ml per hour, to a full feeding. There are mainly three routes of administration: oral, enteral, and parenteral. Oral and enteral, first you should prefer oral feeding to enteral and parenteral feeding. If not possible, enteral and parenteral feeding should be started early, within 48 hours is preferred. If at all possible, oral and enteral routes are preferred routes because it's more cheaper, more physiological, reduces the risk of peptic ulcer, minimizes the mucosal atrophy, may reduce translocation of the bacteria from intestinal lumen. In case of contraindication to oral and enteral nutrition, parenteral nutrition should be complemented within 3 to 7 days. Coming to the oral nutrition, if patient can eat, then you should be encouraged to do so. Oral feeds can be according to the patient's need, calorie calculation you can provide. Enteral via NG tube, nasogastric tube, oral tube, enterostomies, that to support feeding for more than 4 weeks. Post pylori feeding, that is nasojejunal, jejunostomy, etc., for a prolonged period of nutritional support. In enteral feeding, there should be some steps to confirm before start of feeding. Confirm the tube position, secure the tube well, make the patient sit up, start early within 24 hours, aspirate regularly to ensure residual volume is less than 200 ml, avoid bolus feeds, use prokinetics to promote the gastric emptying. Commonly used feeds are hospital prepared foods like hard boiled eggs, soya, milk powder, etc. Polymeric preparation, that is intact proteins, fat and carbohydrates which require digestion prior to the absorption, varies from 0.5 to 2 kilocalorie per ml. The usually given proteins are soya milk, soya oil, soya protein, carbohydrate, malt dextrose. Elemental preparation, that they are readily absorbable, they needn't be digested before absorption. Then disease-specific formulas are also available. For example, for liver disease, decreased sodium and altered amino acid proportions are used. For renal, low phosphate and low potassium diets are used. Specific additives are nowadays recommended, like omega-3 fatty acid and glutamine, to promote the well-being of the patient. Parenteral nutrition. Only absolute indication is GI failure as supplement to enteral nutrition. Usually given as a sterile emulsion of water, protein and lipid, carbohydrate, electrolytes, vitamins and trace elements. Carbohydrates as glucose in parenteral nutrition with concentration of 40, 50 and 70%. Protein given as amino acid and needs to include essential amino acid. Glutamine is also included in the supplementation. Lipid, commonly given as intralipids, provide a source of essential fatty acid, linolenic acid and linoleic acid, giving 6% of the total requirement, that is 500 ml of 20% intralipid, providing 1000 kilocalorie once a week. Electrolytes and micronutrients, some may be included in the emulsion. Depending upon the patient, it's supplemented. That is, in sepsis, vitamin A is supplemented in large quantity. In burns and trauma, zinc, selenium and copper is supplemented in large quantity. Usually the requirement of electrolytes are sodium 1 to 2 millimoles per kilogram per day, potassium 0.7 to 1 millimole per kilogram per day, calcium and magnesium is same as 0.1 millimole per kilogram per day, magnesium phosphate as 0.4 millimole per kilogram per day. Then coming to the complication of nutritional support, first is the refeeding syndrome. Patients who are severely malnourished or have undergone a significant period of starvation are at risk of refeeding syndrome in the initial few days of the support, regardless of the route of the administration. The clinical feature will include weakness, respiratory failure, cardiac failure, arrhythmias, seizures, or death. The mechanism being starvation will cause leakage and decreased transmembrane pumping of the electrolytes, which in turn will reduce the it causes the loss of intracellular electrolyte to the serum, despite the serum value being the normal. Once a carbohydrate is supplemented, there will be insulin-dependent influx of electrolytes to the cell, which causes rapid fall in the serum level of phosphate, magnesium, potassium, and calcium, resulting in the above-mentioned clinical features. At-risk patients should be identified and the feeding must be introduced slowly, starting with only 25 to 50% of the energy requirement and gradually increasing after 4 days. Monitor electrolytes, supplement thiamine and other B vitamins also before starting feeding and daily for at least 3 days. Overfeeding. Deliberate overfeeding to overcome the catabolic state can cause uremia, hyperglycemia, hyperlipidemia, fatty liver, hypercapnia, and fluid overload. Propofol, which is used to give sedation in ICU, should also be included in the calculation of the intralipid to prevent the overfeeding. Hyperglycemia, insulin resistance due to stress response. In critically ill, aim a tight control of glucose 80 to 110 milligram per deciliter. Then specific complications of enteral feeding, aspiration of the feed causing pneumonia, diarrhea due to increased fiber content of the supplemented food or due to any contamination due to exposed to preparation. Specific complication of parenteral nutrition. The parenteral nutrition is usually administered via central line. Risk associated with central line insertion and maintenance like pneumothorax, pylothorax, thrombosis of the catheter, etc. And infection in per se because of the contaminated TPN, that is parenteral nutrition, or due to the contamination of the catheter can occur. The parenteral nutrition may also cause fatty liver, cholestasis, acalculous cholecystitis, electrolyte imbalance, and micronutrient deficiency. That's all.
Very good. But I think, did you mention why nutrition is important for, is it only to replace the micronutrient? Why we are worried about the nutrition of a patient who is critically ill and admitted in ICU or PCU?
Because of the exaggerated catabolic state in the acute phase and chronic phase.
Acute phase, chronic phase, these are all the phases found out to find out how much is utilized by the body and how the body rebuilds. But why we are so worried about the ICU patient nutrition? So there is one article which I read, which asked 5 questions. Why nutrition is important for an ICU patient? Number 1. Number 2, who are the ICU patients who will require nutritional support? 3, when is the nutritional support to be given to the patient? 4, how do you give the nutritional support? And 5, what is the nutritional support you give? If you answer these 5 questions, it will be explained in a much more lucid way of nutrition in ICU. The question answer will be better. Why, first of all, nutrition is required? Second, who requires the nutrition? Third, when should you start the nutrition? Fourth, how do you give the nutrition? 5, what do you give in the nutrition? These 5 questions you should remember. So, without wasting time, I'll just go for the presentation and show you. Is it visible now? Okay. So, medical nutrition therapy. It is not just simply called nutrition, but medical nutrition therapy is an essential part of the care for critically ill patients. But the optimal feeding strategy for patients in the ICU is still debated and often remains a challenge in the ICU team in clinical practice. The important questions you should ask are why, who, when, how, and with what. These 5 questions you should ask. Now, why nutritional status? Medical nutrition therapy in ICU aims at avoiding malnutrition in a primarily well-nutritioned patient. That is a patient who was previously having a normal nutrition. Once he comes into the ICU, you don't feed him properly, you just maintain him only on IV fluids, then he goes into malnutrition. A well-nutrition patient primarily can become a malnutrition patient. You want to avoid that. Second, preventing further deterioration of an already malnourished patient. Supposing a 85-year-old person with a CA stomach, already who has not been eating at home, suddenly develops a sepsis. They have people bring him to the ICU, and already he is marasmic and cachectic. And if you don't ignore the nutrition aspect of it, he will become more malnourished. So you can make a well-nourished patient into a malnourished patient, or you can worsen the malnourished patient who is admitted in ICU. Okay, so this is the first reason why we want to give the nutrition. Second is, if you push the patient to the level of malnutrition, then there is a significant prognostic risk factor for critically ill patients, influencing the major outcomes such as mortality, length of stay. These two things are dependent on duration of mechanical ventilation and infection rates. So if a patient becomes malnourished and if he is on a mechanical ventilator, he will not have enough muscle power to start his own spontaneous respiration, and he will be ventilator dependent for a long time. At the same time, his immunity also will be compromised, and even from an IV site or from bed store or from any other proper septic, aseptic techniques, everything can produce an infection in the patient. So these two things, dependent on mechanical ventilation and recurrent infections, will lead to increase in the length of the stay and will lead to mortality. So these 4 points are the reasons why. The first thing is we want to prevent malnutrition. And why malnutrition should be prevented? Because the patient should be weaned off the ventilator if he is on ventilator, because most of the critically ill or ICU patients will be on mechanical ventilation at some point or other. So we want to wean them off as early as possible, which will not be possible if the nutrition is not taken care of. And patient will become infected repeatedly and will have temperature rise. And again, that the nutrition will be affected, and he will go from a patient who is not well nourished will also become malnourished, and it will become a vicious cycle. So this is the reason why we have to take care of the nutrition. Then coming to who are the patients who require nutrition? Or do all the patients getting admitted to ICU or CCU, do you think all of them will require a nutritional status? No. There are 3 categories. Patients in whom multi-organ insufficiency or failure cannot be prevented or broken through medical nutrition therapy. Patient is very bad. He is very sick. He has already got liver failure, renal failure. He is on renal replacement therapy. He is on all inotropic support. Other systems are also, there is an ARDS, there is a blood sepsis. If all these things are there, if multi-organ failure is there, this patient cannot be salvaged just by giving the nutrition. This is the first category. Second category, the patient, for example, a patient with only a right lobar pneumonia or lower lobe pneumonia. On admission, his fever is 104, 105. But once you start him on the proper antibiotic therapy and give him chest X-ray, you put him on ventilator, within 2-3 days he recovers, the infection gets controlled, and he is on a recovery road within 4-5 days. This patient, do you think will require any nutrition? He will not require. So those who can recover quickly, they also do not require. So this is the second category. First category is a worst scenario where you cannot feed them with nutrition. Second category is a patient who is not going to stay in ICU for a long, who is going to recover quickly. They do not require nutrition. But the third category, in whom the disease course may be positively influenced by an individualized medical nutrition therapy. So the patient is likely to stay in the ICU for quite some time, but he has not gone in for multi-organ failure. But at the same time, he is not expected to recover so fast, like 4 days or 5 days. He is going to stay at least for 2 weeks or 3 weeks. But there is a good hope that he can come back and recover and that is the patient where you have to take care of the nutrition. So who, for this question, who, this is the category you have to think of. It may be easy to identify an undernourished patient with low body weight and BMI during clinical routine. But in case of an elevated, supposing an obese patient comes, it will be very difficult to detect malnutrition in this patient. So among the patients who is a normal weight or normal, slightly lower body weight at BMI, you can easily detect whether they have lost weight. But if it's a grossly obese patient who is coming and getting admitted, detecting nutrition, because they will not become immediately skinny in the next within 2 days. They will still look plump and chubby, so it may be very difficult to detect a malnutrition in them. And the another added problem here is there are no validated and recommended tools to estimate the nutritional status of a critically ill patient. So, but you can assess the risk of who are all the patients who will can develop or become malnutrition is assessed by the nutrition risk score, Nutric score, and subjective global assessment, malnutrition, universal screening tools. These are all some of the names that you have to write in your theory paper to say that they are used for assessing the risk that some patients who are the patients who can develop malnutrition if you don't take care of that nutrition. So you must take into consideration the medical history, age, comorbidities, and loss of physical function, and then nutrition history, whether the patient has previously itself was not eating well, and whether he had a weight loss. For example, a patient with a liver failure may be having vomiting and not eating properly, repeated jaundice. All these patients may come with a history of weight loss, or cancer patients who are not able to eat with reduced food intake and appetite. They will come with a weight loss. So the nutrition history prior to ICU admission is very important. Then you examine the patient physically for BMI, edema, and body composition and severity of disease. What is the critical illness for which they have got admitted? These things have to be, and weighing critically ill patients may be mandatory, but it may be difficult. But that problem is overcome nowadays by, in most sophisticated CCUs and ICUs, they have weighing beds where the patient, when he lies, you can just switch on the uh, weighing scale. It will immediately reflect the patient's weight, because already the mattress weight and other things have been calculated, and it will give you the patient's weight at any time. So weighing is not a problem nowadays with the beds which are available to weigh the patient anytime you want. And changes in volume status is a very important thing. A patient who is in congestive failure, who has got a fluid overload, his weight will be artificially increased. It may not be because of lack of nutrition. So he may be malnourished, but his weight may be normal. So that will give a little bit of trouble for assessing the nutritional status using the anthropometric values. And the ESPN guideline defines every patient who is in ICU for more than 48 hours is at the risk of malnutrition or nutritional deficiency. So any patient who is likely to stay for more than 48 hours, we must try to uh, look into the nutritional aspect also. And regarding technical tools, we can use a CT scan analysis, musculoskeletal ultrasound, bioelectrical impedance analysis, which are all very high-end PCUs you may have. And for this, you can use the assess the nutritional status, but they are not broadly available in all the situations. Now comes the question how to give the nutrition. So we saw why nutrition, who nutrition, and how nutrition, how to give the nutrition. Enteral nutrition is available. This is a physiological advantage. What all she said, if you don't use the gut, you lose it. That is the saying. That so you have to, as early as possible, start using the gut. And the adverse effect of parenteral nutrition in earlier decades is another reason to insist on switching over to or starting enteral nutrition as early as possible. And cost effectiveness, it is much more cheaper to give enteral nutrition than parenteral nutrition. And another point I think, Ammu, you missed is what are all the important contraindications for enteral nutrition, which include hemodynamic instability. As the ICU and CCU patients may come to the ICU with a severe hemodynamic instability. They may be in hypotension for a number of hours. And they may require IV vasopressor support, and we may have increased lactate. So when there is a hemodynamic instability, starting enteral nutrition is very, very risky because it can cause gut ischemia, and perforation also can happen. So unless the patient is hemodynamically stable, you should not start enteral nutrition. And another thing is, if there is a mechanical obstruction in the gut, for example, a volvulus or a cyst perforation, and the gut is not working, and if there is a growth, all these mechanical obstructions also is another important contraindication for starting the enteral route of nutrition supplementation. So any gastric volume more than 500 ml in 6 hours or acute gastrointestinal injury grade 2 are all contraindications for enteral nutrition. Then you can combine enteral nutrition with parenteral nutrition. Enteral nutrition may be preferred in almost all ICU patients. Macronutrient targets may not be reached with enteral nutrition alone in acute phase. What do you mean by this macronutrients? It's the lipids, glucose, and fat. These are three things which commonly include our day-to-day food. They are called macronutrients. So the macronutrient targets may not be reached with EN alone in acute phase when the patient is not able to take. So their addition of parenteral nutrition or the use of that total parenteral nutrition for temporarily may help the patient to meet his nutritional demands. Now, how much should be given? You must calculate the energy and protein requirements. So, prefer indirect calorimetry to measure energy expenditure. This is a most important modern. This indirect calorimetry can be asked as a short note question also in your theory, because this is a newer investigation which is being considered very useful to calculate the energy and protein requirements of these patients. And weight adapted formulas also may be used alternatively, and the minimum energy required is 24 to 30 kilocalories per kg per day, and out of which protein should be 1 to 2 grams per kg per day. And do not neglect non-nutritional calories. What is non-nutritional calories? This is what she said about using propofol for sedation. So in ICU, we use propofol sedation for even 24 to 48 hours. And propofol contains the lipids, but they don't add to the nutritional value. So they are all non-nutritional calories, and that also should be taken into account. And when should you do the timing of nutrition? Initiate enteral nutrition within 24 to 48 hours if there are no contraindications. Optimize enteral nutrition delivery. Addition of parenteral nutrition needs individual adaptation. And what is the solution or nutrition you give? Formula consideration. Standard formulas to be chosen for most ICU patients. Consider energy dense formulas in patients with fluid restriction and in malnourished patients. And intensified blood sugar monitoring is very important when you give energy dense formula, that is high calorie formulas. If you give, you have to watch for the rise in blood sugar also. And this is the phase according to which to start the older classification of F phase, flow phase. F phase within first 24 hours, that is in acute trauma or burns. All these things will have this first hour of 24 hours is the F phase, where maintenance of blood volume and catecholamine secretion is a major change, adaptation that happens. And physiologically, there is a decrease in BMR, decrease in temperature, decrease in oxygen consumption, vasoconstriction, increase in cardiac output, increase in heart rate, and acute phase proteins are released. So this will be the change in the first 24 hours. And the hormones responsible for that are the catecholamine, cortisol, and aldosterone. After 24 hours, the flow phase starts, which is early, as we mentioned, can be catabolic, starting from third day to 10 days. There, the maintenance of energy is the main role, and there is an increase in BMR. This is the time temperature increases, oxygen consumption increases, and negative nitrogen balance also occurs. And the hormones playing a role in this are the insulin, glucagon, cortisol, catecholamines, and but insulin resistance also can happen and hyperglycemia can happen. Later, the anabolic phase sets in where it is to repair and replace all the tissues that have been damaged. So that's a positive nitrogen balance, and that is mainly done by growth hormone and insulin-like growth factors. Okay. So supplementation with specific nutrients, you have to choose some specific immune enhancing and anti-inflammatory nutrition. It's a challenging and controversial issue. So for that you use arginine, glutamine, omega-3 fatty acids. But these are all, as I said in the very first sentence, they are all debated very much. Some people agree with this, some people don't agree. But you have to mention this in your answer that selenium, vitamin D, vitamin C are all uh, used. And there is a Maric cocktail, the treatment with intravenous hydrocortisone, ascorbic acid, and thiamine in septic patients, even though found no significant difference in long-term mortality, is still used as a trial in patients who are under severe sepsis. So that is short form is HAT, hydrocortisone, ascorbic acid, and thiamine. I don't know what is the composition, how much is the dose. And proven micronutrient deficiencies need to be treated, but not as a routine. This micronutrient only includes all your potassium, magnesium, calcium, and all these vitamins, everything can be included in micronutrient and supplemented whenever parenteral nutrition is administered. And how do you monitor the nutrition and what are all the complications of nutrition is the next thing that you have to mention. Clinical examination of the patient's abdomen, blood biochemistry for serum glucose, triglycerides, lactate, and procalcitonin. And phosphate should be controlled to detect treat the potential refeeding syndrome. The complication, right, he very well mentioned, is the refeeding syndrome. And urea excretion rate per 24 hours will help estimate the catabolism. For estimation of intestinal function, there are biomarkers available now, which are called citrulline and fatty acid binding protein, which are found in the plasma itself. And for gastrointestinal intolerance, you have many critically ill patients experiencing feeding intolerance, motility disorders, which may be in the form of either constipation or diarrhea. So that is another problem in enteral feeding, gastrointestinal intolerance. And causes of GI intolerance are too much of opioid analgesia, sedation, edema, and insufficient stimulation. That is why nowadays, if a patient is sufficiently having muscle power, we try to mobilize them even in ICU as early as possible. Make them sit up, make them get down from the cot and sit in a chair for some time. So these are all stimulations for the leg to perform well. So sedating the patient too much or giving opioids will all cause GI intolerance. And treatment options are oral, intral, prokinetics can be given, mobilization can be done as early as possible, physical therapy, and optimization of sedation and volume status. If you do all this, you can prevent and or treat the GI intolerance. And clinical observation of patient's abdomen, bowel motility, and gastric reflex is mandatory. Then patients can also develop metabolic intolerance. Hyperglycemia may be due to hyperalimentation, in acute phase where insulin resistance is one of the cause, or there may be underlying subclinical diabetes also, which has not been detected earlier, may be the reason. Hypertriglyceridemia is another metabolic intolerance caused by bolus application of lipids, prevented by bolus application of lipids, and reversible liver steatosis or hypertriglyceridemia, which may come sometimes induce an acute pancreatitis. Metabolic control is not achieved quickly, and in severely malnourished patients, after long starving periods, when you start, supposing you have missed out years earlier itself before admission, patient has not eaten well, and you enthusiastically give him a lot of feeds in the enteral route, then you can develop what is called the refeeding syndrome, which can occur in the first few days after starting nutrition therapy. The supply of carbohydrates and fluid will stimulate insulin secretion and shift all the glucose and electrolytes into the intracellular compartments. This will decrease potassium, magnesium, and phosphate. This phosphate loss or hypophosphatemia is considered as the main reason, because phosphate is very important for our energy manufacturing purpose. ATP, adenosine triphosphate, is our energy store. So when the phosphate levels are low, ATP production will be very much impaired, which will lead to impaired neuromuscular transmission, causing life-threatening arrhythmias or convulsions. And calories and fluid administration should be increased slowly for this reason, especially if patient has not had enough nutrition earlier. When you start nutrition enteral, you have to go gradually under electrolyte and preferably ECG monitoring. In high risk patients, the preventive thiamine administration of 200 milligram once daily for 2 days is necessary to prevent this refeeding syndrome. And this is the algorithm that you can follow for ICU protocol based on practice guidelines. On patient admission, check if the patient is hemodynamically stable. This is the first and foremost criteria before you think of nutrition. If the patient is not hemodynamically stable, wait for stabilization. This is the first mantra that you should get into your mind very well. Second thing, screening and assessment for nutrition. If he is stable, then you screen for the status of nutrition, assess for malnutrition, calculate the nutrition requirements. Once you calculate the nutrition, can you start enteral feeding? That is the next question you ask. If the question is yes, there is no contraindication for starting enteral feeding, you choose whether you can go for oral or tube feeding. With the monitor patient's intake, start on if requirement is not met, you have to go for other methods. So tube feeding can be within 24 to 48 hours. If the patient's enteral feeding is not to be initiated, think of parenteral nutrition. If the patient is very severely malnourished, otherwise wait for the opportunity to start the enteral feeding and start early, advance towards full goal gradually. Start with standard polymeric formula, Profit feeds of 10 to 20 ml per hour. Check tolerance of the patient. Don't blindly go on feeding the patient. Always review and see whether he is able to tolerate the enteral feed. In the patient's tolerating feeds, start and increase calories slowly, gradually. If the patient is not tolerating the feeds, evaluate symptoms, and if patient is unconscious, then check aspirate, check other reasons for intolerance, measure the measures to improve the tolerance if to be followed, and switch to semi-enteral feeding also. These are all the things that you have to follow for that, which will be quite time consuming to go through. And lastly, tailoring the nutrition for individual patients. This also you should add into that. That is, you must see whether there is a pre-existing malnutrition. Then go for early nutrition. Micronutrition deficit should be thought of, pre-feeding syndrome, and check what is the outcome. Patients may be obese, then think of these things. substrate utilization, delaying metabolism, and comorbidities and metabolic syndrome. If the patient is admitted with a central nervous system like stroke or head injury, then high risk prolonged ICU stay is possible, and dysphagia and aspiration is possible. So frequent DA dysmobility may be there. Then septic patients, early enteral feeding when they are hemodynamically stable, metabolic and GI intolerance can happen, disturb the substrate utilization and happen in septic patients. Elderly patients, respiratory system deficiency, cardiovascular trauma and burns and gastrointestinal tract problems, all these renal problems. So these are all the specific indications where you have to, as you mentioned, modify your nutrition. But the basic principles are every ICU patient is at the risk of malnutrition, and regular screening for malnutrition should be done. Close monitoring and frequent adaptation of nutrition should be done, and early enteral nutrition is preferred. Micronutrients are mandatory if parenteral nutrition is the only method that is can be used, and you have to individually do adaptation for the patient. So it is not one fits all. It has to be individualized. And but the best thing is nowadays in most of the hospitals there is a nutritionist available. So in consultation with them, the intensivist usually plan. So the headache is taken off from the intensivist. But unless you have a basic knowledge of how to treat the nutrition in the ICU patient, you may not be able to supervise whether the nutritionist is doing their job correctly or not. So that is the reason why we want to have an idea about nutrition. And this question is several times asked in the theory paper, and I hope you are able to have a reasonably good idea about it. Okay.
Okay, sir. Thank you, sir.
Thank you, sir. Any doubts from students?